introducing everybody out.
Okay, hi everyone. I'm Karen Gordon.
Lisa Park.
And we're very happy to follow beautiful lecture from Jill. Thanks so much for that. We have a very short time for our panel. So what we decided to do for efficiency is to get your input right up front. And Lisa has done a beautiful job putting all those poll questions together. You're going to have 8 questions. We want your response. Maybe you want to show the poll?
Sure.
We're going to do them all together, and then we're going to have the panel discuss and see what they think of those answers.
Where'd we go?
So we are going to need our slides, otherwise nobody's going to know where that poll is.
There we go.
Okay.
So you want to log in, you can use the QR code, or you can go to the website, whatever works best for you. Now, our first question is, in your experience, what is the motivation for an adult with unilateral hearing loss to pursue a cochlear implant? You can just rank these, slide them into what order you think they should be in.
Yeah, we might need the code back. Oh, it's right there.
Yeah.
It's right there.
You can use the same.
Do you want to do it?
I would say, should I duck, but who are we kidding?
We'll see how it goes.
Trying to do raise your hand. I left my phone.
We'll just keep going for now, and they should show up when we go to the...
Oh, nice.
What about for children? What is your experience?
The code is too small.
Do you want to go back? Lisa, do you want to go back?
Thank you. Make sure it works for me, too.
Yeah. All right. Is that poll working? That
It
is
doesn't
what I wanted
seem
to
to
know.
be working.
Yeah.
This might be a little bit.
Okay, so we'll just put these up as hypotheticals, and we'll come back and discuss them.
I don't think it's.
Is it working?
Did you get it? It's not really working. Okay. All right. So you know what?
They pop back up, so we can just discuss them.
Okay. We'll do that. That's fine. No, that's okay. Don't worry. It wouldn't be good. Is that? You go ahead and I'll come.
Okay. All right, so we'll introduce our panel, and then we'll come back around here and talk about those questions. So we have Dr. Karen Gordon from the University of Toronto, and we have Dr. Jill First from Washington University in St. Louis. We have Alicia Pillion from Walter Reed, and we have Dr. Sharon Cushing from Sick Kids in Toronto, and myself, Lisa Park from UNC. So our first question for the group is, in your experience, what is the main motivation for an adult with unilateral hearing loss to pursue a cochlear implant? For our panel.
I think I'll take this one. Boop. Buzz in. Okay. All right. So I'm Alicia Pillion. I work at Walter Reed, and I primarily work with patients with single-sided deafness. It's the bulk of my caseload, and I would say I've seen patients come in for tinnitus, the present hearing challenges, and concerns about future challenges. But the bulk of my patient load are patients who are in their 20s, 30s, 40s, 50s, 60s, like this younger crowd that are still very active, and they are isolating, and they have, on our quality of life survey, they are equating their hearing loss to just as impactful as patients with bilateral sensorineural hearing loss. So they're not as active in their lives, and there's a fear that they're going to, in the future, potentially lose their hearing in their other ear, and that's why they tend to move forward with it.
Dr. First, do you agree, disagree?
What did you think? You have to keep.
Okay, all right, I hear myself now. Yeah, I think for us that it's related to their present hearing challenges as far as wanting to get a cochlear implant. I know some patients do mention the fear of losing the hearing in the good ear, but I think it's more related to their present hearing challenges, wanting to hear better in noise, localized, and so forth.
So maybe because we don't have the poll, maybe what we could do is ask somebody who agrees. Does anyone agree who wants to speak up? Or people who would think of a different idea? We'd love to hear from you guys out there. Looks like everybody's in agreement with you guys. Okay.
Great. Okay, so how about when we're talking about children, what seems to be the main motivation there?
Buzz in.
All right. So, I think for kids, families come in, and they're in grief that their child has hearing loss. And what they would like is normalcy. And whether that means, academic performance or social performance, I think that's what they want, is for their child not to have a barrier to living their best life. I think as clinicians, we bring up the other things like bilateral brain development and potential risk to contralateral hearing, especially depending on etiologies like CMV. But I think, families just don't want their child to have a barrier.
So I think we should follow up on that. So let's think about the idea of balance and what do you think, even though families may not be aware of that, should they be aware of it for children with single-sided deafness?
Absolutely. So, we looked at a cohort of kids with single-sided deafness, and we looked at their vestibular function and their balance function, and their balance is poor. And it's poorest when there's also compromise of the vestibular system, which there is in about 50% of children with single-sided deafness. But it's even poor in those children with intact vestibular function, because hearing is, quite important in the maintenance of balance. Whether or not giving an implant is going to fix that, that's a whole other question. But certainly I think balance is a reasonable concern, and I would suggest that a child with vestibular deficits and single-sided deafness is probably even a better candidate than a child with single-sided deafness alone.
Yeah, so balance may not be something that people are thinking about, and I think that the health and the long-term hearing in the better hearing ear is also something we really need to consider, and this was brought up in a previous panel in the Stump the Experts panel, is that consideration of the better ear. And Jill, you were talking about that a lot in your talk. Do you have any comments on the progression? How important is that for you?
Oh yeah, we always want to track the better ear, and it's even more important when there's hearing loss in one ear. So we definitely want to track that, and our clinical trials are tracking the better ear so that we can know what is happening with that ear.
And I am seeing these questions coming in that people are putting on the last page of the poll. So keep them coming, and when I see them pop up and they match what we're talking about, I will ask our panelists. What should be exclusionary for cochlear implant criteria candidacy in adults?
I will take this one. So for me, it's a unilateral deprivation since childhood. I don't follow the 10-year guideline, but if someone has come in and they're like in their 50s and they're like, oh, I haven't heard in my ear since I was a kid, you're probably not a good candidate. But in addition to that, I also have all of my patients do a minimum 30-day cross trial prior to proceeding with a cochlear implant. And I know that some other clinics may not do that, but it actually gives me really good information, because if a patient I give them a loaner device. If they can't go out for 30 days and keep track of that, if they email me a bunch, if they've lost it in that, just a week or a couple days, like, you're probably not a really good candidate for a cochlear implant. So.
Jill, you had a pretty positive comment about even with long durations of deafness for effects in adults. So is there anything that would make you pause for giving an implant to an adult? You mentioned, prelingual onset.
Right. Well, as far as duration of deafness, I mean, I agree. We have people with deafness way longer than 10 years who are doing well with an implant. So I don't really see that as needing to be an exclusion. I think it's definitely related to age at onset, and so that is a critical factor. We usually have people wait 6 months. I'm just looking at the other bullet, and just to ensure that the hearing doesn't come back. In rare cases, it does, but for the most part, we typically see it does not, but we still try to wait. And even if they're going through the evaluation, by the time perhaps they have surgery and so forth, it would be 6 months, and we would feel assured about that. I think that it can be a good experience for people to try, a cross hearing aid. I mean, certainly they need to be counseled that those are options. Sometimes adults may not be interested in that, and what they really want is to hear in that deaf ear. But I think it is important for them to understand what the options are, and I know for pediatrics we are certainly doing it.
So we put in this question about limited unilateral deprivation. It's something that we never talk about, but it's something that I became concerned about when we acted really quickly in adolescence. And one of our concerns about non-use in those adolescents with really short durations of single-sided deafness was, well, maybe we didn't give them enough time to get used to that deficit. Do you have any comments maybe about, just living with the single-sided deafness for somebody who's experienced a sudden onset, and it would be postlingual?
So you're talking children now?
It could be, well, we were thinking that the teenagers are postlingual, so they should look a lot like the adults.
Right.
But do you think there's like a minimum amount of time that people should be living with their single-sided deafness before going on to pursue a cochlear implant?
I think we've always thought about it in terms of, is the hearing going to come back, as opposed to you should live with this for a while. I think it's just important that people really understand what we're looking at when we're talking about getting a cochlear implant. I think the teenagers, there's a whole nother set of, of factors with that population. So I don't know, I'd be interested in Lisa's comments.
Actually, a good question just came through about adults, so I'm going to, flip that around.
Okay.
Patient motivation. Do you feel like patient motivation in adults outweighs their age of onset of hearing loss in terms of candidacy?
Yes.
Yes.
Yes, yes. Or I'll
Good.
buzz in. Yeah, I would say I've had patients who we've implanted and they've had a duration of deafness of 20 to 30 years. And they may not have really good outcomes, but they're like regular wearers. They wear it all day, and they really like their sound processors. Like on quality of life survey, they are regular, or they're happy with their devices, but they may not be like the best performers. So it really depends on counseling, like what they're expecting to get out of it.
Yeah, and a lot of the data, I was showing today is CNC words through the implant ear alone. It's kind of like the gold standard for how clear is speech through the cochlear implant. So it gives us some indication. It's certainly not the only metric. And so looking at other metrics, looking at bimodal metrics, and also just patient satisfaction. Even with traditional CI patients with bilateral hearing loss, they may not be the highest performers, but they may love their implants. So, we can see that same thing with the SSD population.
True.
Yeah. For children, things are a little bit more black and white for some things, like unilateral cochlear nerve deficiency. I know at our center that's not something that we are implanting at this point. For cochlear malformations, major malformations, anything more than an IP2 or an EVA, we haven't gone there yet, just because being able to match the tonotypicity between ears is going to be next to impossible in that case. From our standpoint, duration of deafness just requires a lot of counseling about expectations. We don't have a cutoff. We don't say, oh, you've been deaf too long, we're not going to give you a cochlear implant. But we will talk about, you're a teenager, do you really want this? Because this is what it's going to take, and you're going to have to wear it all the time, and this is what it looks like. Do you want to do this? Because if they don't want to do it, they're not going to be successful. So for us, it's not as much duration of deafness as it is their motivation.
I think, for us, in terms of an absent auditory nerve or even a hypoplastic auditory nerve, it's a hard no in our program. And, there's a few things that I think about when I have a hard time saying no generally, but not to this question. Karen knows that. And one of the things that I think about is, what are we trying to do here, and what are the sort of the personal and systemic factors that are influencing it? And if I look inward, before we give any talk, I put a set of disclosures up on the slide. But the one that I never put up there as a surgeon is that I get paid to operate. The other part is that the tool I have to fix things is a cochlear implant, but it's not always the right tool. And so sometimes my heart wants to give a child an implant or do something good for a family, but it's not the right tool. So I think we have to have a little bit of inward reflection, especially in these types of cases, because we're burdening a family with a device, an expense, another thing on their busy parent to-do list when it's not going to work. And is clear to us in that scenario.
Yeah, I think that heart comes from a good place. I think we really understand, and again, Jill, you spoke about this beautifully, that there is going to be a developmental impact of growing up with one hearing ear. So we want to help. The question is whether the cochlear implant is the right help, and that's what we're learning. That's where that gap is between, what we're doing and what should be the standard of care going forward as we learn more. I think the use data is really important here. And our data look in our 70 or 75 children with SSD look very much like what you were showing, Jill, where we have some users and we have a higher rate than we would like of non-users. And I think we just have to put that out there. And this is over years, and we are seeing changes and decreasing use over time. And we have to look out for that, which tells us something. When we measure speech perception outcomes and benefits, we see it. They can do beautifully with this implant. The concern is why then we have some who choose not to wear it. And that's something we're going to have to keep in mind when we are talking about expectations for children and counseling for children who are coming to us for help, which we really want to provide them. So I think this now comes to our next question here, is what are we talking about with respect to realistic expectations? So here what we're thinking is when we're talking to families about what should they expect for their child, they know that they're at risk for developmental differences because of this single-sided hearing. So what do they want, and what do you think we're going to tell them they're going to get realistically? Want to try that?
Well, everything that's listed is a possibility. So I think, we see that, in our data, in our clinical experiences, that children show benefit in many of those areas. It's still difficult to know which children are going to show which benefit, but I think all of those are possibilities.
I think we see the localization happen really quickly. Like that seems to be the first thing that families really notice that, and just things that they didn't even know were really a problem. Like, wow, they really answer to me a lot more quickly than they used to, or they seem more focused. Like those sorts of things that weren't really on their radar as a problem are the things that we see change right off the bat. And those are things I feel more confident telling families that they would likely be able to see in their child. Hearing and noise seems to take a little bit longer to develop, but it's certainly within the realm of possibilities.
And do we know anything about hearing fatigue? I noticed you had those scales in your battery. I don't know if you have any kind of hints about what you're finding there.
I don't have any hints. We haven't looked at the data yet, so I can't really speak about it.
Yeah. And the academics, similarly, that's going to take time for that to weigh out, whether we really are making any kind of headway on that. So I think, we're not going to be able to really help parents with that question with any hard data. Of course, that's what they might want, but we just have to be careful with that.
A question I'd love to hear from everybody. What do you think our test battery should look like? What should we be measuring? Because I don't think that single words is it. I think we need something different for this population. What do you think it should be?
So I think that some of this fatigue issue is really important, and we probably over all of our measures, not in just this population, but across, should probably go beyond our accuracy on these measures into reaction times, fatigue, other kinds of measures which get at these subtle ways of hearing. I think also this mention that Jill, you had about interference and what does that mean for a child with SSD, because you may be able to do quite well in a speech perception and still be bothered or have information from one ear that's not well matched to the other. We don't really know how that affects how they're doing in complex listening situations. So I think I'm going to ask you, Alicia, you're not going to talk. So they have some beautiful data on adults trying to test interference for listening in adults with SSD using a CI. Can you talk about
Thanks,
that?
Karen.
Sorry, I'm going to put you on the spot because you are on the panel.
I work with Josh Bernstein, who is a prominent researcher in SSD, and he does have some really good data on interference and attending to listening through the implanted ear and masking noise. Can I talk directly, too much about it?
No, but I think that's it's an important idea of how well can we measure speech perception amidst interfering speech. So I don't think you need to give the specifics of it, but we do need to look at these more complex listening situations like those paradigms to get a sense of not only the accuracy, but the fatigue and the effort that's involved in that.
What about social aspects for children? Where do you think SSD and cochlear implantation fit in terms of social development?
I think, it's important, especially for children, to be able to hear from both sides, even if they're not able to get true localization. Just having the capacity to hear a playmate who's on one side versus a playmate who's on the other side. And I think that's super important because kids don't do what we do, which is talk to each other, look each other in the eyes. They're moving, they're talking. And so I think that part is socially important. The other component is when they become teenagers, and we certainly measure in our teenagers, and they share with us that they struggle with social interactions and even the effort of thinking about where am I going to sit relative to the speaker and not being able to hear your teenage friend on the other side. So I think there's lots of subtle things that a cochlear implant will make better but not perfect.
Let's see. We're wrapping up on time here.
Can we go back to the realistic expectations of adults?
Yeah.
Because we might have skipped that a little bit. We have a lot of data that we collect, and when I first started out working with SSD patients, I would tell them that they would get better on like everything, on your speech scores, your CNCs, your speech and noise, your localization, and spatial hearing. But we have an SSD protocol, and we do testing with a 7-speaker array for localization and speech and noise testing. And our data shows that, similar to what you were showing, on localization, not everyone does very well. So they're able to localize and say something is on like this side of my head, but they're not able to like pinpoint where that is. So, and some of our patients too, they have that good low frequency hearing, and I counsel them that like if you go through implantation, there's a potential that you could lose that hearing, and you could lose that ability to localize, but you could be gaining so much more because you do, everyone performs so much better on the other scales, so, or test, excuse me. So, sorry, I just wanted to.
Maybe we could talk about localization for a little bit, because the idea of these mismatches between the ears is really going to have a massive impact on localization. And we do see that the kids who are using or have bimodal hearing, using the implant with the other ear, with or without a hearing aid, is quite a bit poorer, because we think it's that they don't have the same access even to interoral level cues. The mismatch of frequency is so different, and those timing cues are hugely different between the two devices. So maybe we could, I'd love to hear everybody's impression on what do you think when you see those improvements in localization? What do you think is really happening there? Does our data show kind of there's some improvement, not a huge amount, and there's really no perception of direction of moving sounds. So how do we interpret these improvements in localization?
I think mostly they're using level cues. I haven't done any work with moving targets or anything like that, but from what I've seen, I think it's mostly level cues. And one of the reasons I think that is because one of my kids walked out of the booth and said, "You know how I know if it's louder on this side, it's over there." And I was like, okay, got it. Because we also will see some benefit in these kids when they take their devices off over time. Some of that is probably just maturation, but also I think that they are learning some cues that they can carry over into their unaided situations, which says to me that it's not truly a binaural benefit that they're using just yet. Maybe that comes down the road, but I think early on it's definitely level cues that they're using. I think we really need to look to our manufacturers to help us get them better timing cues.
Well, maybe we can use that as a segue to this idea of therapy, because I think, using the device, even understanding there is a spatial world around them, that's maybe a new concept. And so the therapy and the support that we're giving to the children and adults once we give a cochlear implant, what should we be doing to help them along that process? So we start with adults. The next question is children.
Okay.
Yeah, I think that adults with SSD benefit from training. So at WashU, we've always had a strong oral rehab program for all of our patients getting cochlear implants. And I think it's very important, maybe even more important, for the group with SSD and practicing at home. And this is, in my talk, that was one of the questions that I have. I really think we need to look at this more, because we find that patients who are doing a lot of practice at home and streaming and so forth are seemingly doing better, and then when they stop practicing, their scores kind of go down. So anyway, I do think that the practice with adults is very important. If there's no rehabilitation available for them or guidance for them to do things at home, then just wearing the device as much as possible, is going to be the best experience that they can have as far as training, is just keeping the device on all the time.
I absolutely agree with that. So I counsel my patients to do direct streaming through their sound processor and do it as much as they can in the first few weeks to months, and then they can taper off a little bit, but it's good to at least do a minimum of an hour a day of direct streaming through their sound processor.
I will say my highest performer she streams video games to her implant ear as her practice, and her favorite game to play is Animal Crossing. So I don't know if you played that, but they're not words. But she's a fantastic CI user, and her dad's always like, can you tell her to stop doing that? And I'm like, nope, sorry, can't be with you on that one. Because I see the same thing. If they stop with the practice, their scores will go down.
Yeah.
And we're exploring what will work for practice. So, I think this idea of trying to provide some spatial awareness through this bilateral, bimodal hearing is really important. So there may be a role for combining other sensory modalities. So, the vision, where is that sound coming from with, then how do you figure out that it is on that side, getting some spatial awareness beyond the language, right? Because these kids generally are going to get their language through the other ear, but we're going to have to get to noisy situations, trying to get them into situations where there's more than one speaker, and trying to help them navigate in a way to help them in those places where we hope the implant will be effective.
Our time is up. I wish we could sit and nerd out on SSD all day. But thank you to all of our wonderful panel members for being here, and thank you for questions.